Hi there, I'm Dr. Jessica Hellings, and I'd firstly like to welcome you all to this talk. I'm a child psychiatrist on faculty as a professor at the University of Missouri in Kansas City, and I've been treating individuals with psychiatric illness and intellectual and developmental disabilities and autism spectrum disorders for almost 30 years. And one of the reasons I really like to treat this population is that I like to open doors for people. And by that I mean that most doors are closed for individuals with developmental disabilities and autism, including in terms of obtaining psychiatric treatment. And as you know, as individuals yourselves who treat people with psychiatric illness, with a small amount of treatment and some other services, a person can really improve in terms of their quality of life. And one can also see the improvements in the quality of life around people that are serving them or living with them. So apart from this, it's a tremendously fun population to work with, since they have a wonderful outlook on life, and seeing the improvements with small adjustments in their services and medication is very gratifying. So today we're going to talk about psychiatric assessment and workup in developmental disabilities, and my goal is to show you how, as a person that's familiar with general psychiatric practice, you can, with some small innovations to what you do, can really serve these people and make things flow well for them in your practice. Now, my disclosures are that I'm a present or past investigator for Shire, Forest, Young Living, Synovion, NICHD, and NIMH. So the psychiatrist role in autism spectrum disorders: why would anybody want to consult a psychiatrist with autism spectrum disorders? Firstly, psychiatric illness incidence is 3 to 4 times greater in people with autism than in typically developing individuals. And the psychiatrist is often called upon to prescribe medications when things are not going well and serious behavior problems occur. So the behavior problems often also have not responded to behavioral interventions or cannot be contained. In addition, improving the person's attention span, if they have inattention, can improve their speech and developmental advances and make them more able to comply with extra services that they may be receiving, such as occupational therapy or speech and language therapy. So furthermore, when the psychiatrist is seeing one of these patients, they are asked to treat aggression, hyperactivity, self-injury, and property destruction, which are common presenting complaints. And this is often what throws a psychiatrist off if they're not familiar with this population, because what they need to do is to work out how these presenting complaints can be diagnosed in terms of DSM, DSM-5 disorders, or Diagnostic Manual of Intellectual Disability Disorders. We'll talk a bit more about that. So the psychiatrist, in addition, must judge whether such problems relate to environmental stressors or medical illness, which is much more common in this population and often missed, medications that are being used, or psychiatric diagnoses. So part of our role is to assess the unmet needs of the patient in addition. So for example, are they getting enough sleep? Are they having difficulties communicating their thoughts and needs? Do they need more structure and routine, more fun in their lives, and how are their emotional attachments working? So there is, in addition to DSM-5 diagnoses, a diagnostic manual called the DMID-2, which is a crosswalk deliberately based on the DSM-5 that will help clinicians via tables and chapters and discussions as to how diagnoses can differ in people with autism spectrum disorders. So this is the DMID-2, and you're all referred to this for more information about what we're going to talk about today. So it is vital to get to know the patient and their daily life, the same as it is in general practice, but since many of these folks are unusual in their presentations or quirky or have communication difficulties, it's even more important to get to know the patient. Try to imagine yourself how you would feel if you were in their situation. Would you be happy, sad, or disillusioned, or very frustrated and hostile? So this will provide you with clues as to what to recommend should be changed about them. The use of daily behavioral data is helpful, and you can just help advise on how to collect this kind of information in terms of good days, bad days, number of outbursts in a day. While the psychiatrist can diagnose ASD using DSM-5 and DMID-2 criteria, we can also get an autism diagnosis by a developmental pediatrician or psychologist if necessary. So we're going to talk more about the psychiatric aspects of treatment, but it is quite possible that a psychiatrist can write a letter including the reasons for a person being diagnosed with an autism spectrum disorder. So firstly, we'll talk about co-occurring psychiatric diagnoses. These help guide the selection of the most appropriate medications and interventions to try. Rather than asking for a list of medications that the patient has tried and then trying medications they have not tried, the actual diagnosis, the same as in our general practice, is used to guide what class of medications we should try. So all DSM-5 and DMID-2 diagnoses can occur in individuals with ASD, but the actual presentation may be different or atypical, and that's where your experience and knowledge will come into it. So examples of co-occurring psychiatric diagnoses include attention deficit hyperactivity disorder, depressive disorders, psychotic disorders, bipolar disorders, motor disorders, anxiety disorders, trauma-related disorders such as PTSD, gender dysphoria, and substance abuse. So diagnostic overshadowing is an important concept that was described by Steve Rees and his colleagues in 1982 that describes incorrectly attributing psychiatric illness and behavior problems to the underlying disability. And this is especially important when the psychiatric and behavior problems are potentially treatable. So a basic example would be to say that it's understandable that somebody with Down syndrome should feel and act depressed because they're different from typical developing individuals. Whereas co-occurring major depression might actually be what's going on and may respond well to therapy or medications. So now we're going to talk a little bit about preparing for patient visits. So the caveat is that most individuals with autism spectrum disorders and intellectual and developmental disabilities are relatively high functioning, and they can navigate a patient visit just like anybody else would in your waiting room and your visit room. But there is a smaller proportion of individuals with autism spectrum disorders that are going to not want to be in your waiting room or in your consultation room and are going to be having serious behavior problems or behavioral challenges. So because of this, it's important to establish on intake if the patient is going to likely be agitated, and then have them booked first appointment in the morning or after lunch so they don't have to wait. advise that they should come with separate staff and transportation so that they can leave with those people and somebody else can stay to complete the history, or otherwise we can complete the history over the telephone later. Alert staff to take the patient and caregiver back to a large, quiet room immediately on arrival and monitor safety concerns. So remove objects that can be thrown, try to have a large conference room without windows, and if necessary, turn the lights down. So advise to bring healthy snacks, an iPad, or favored items that are going to help the person feel more comfortable in the room. In addition, look through any records beforehand if you can. See a patient in the large room, as we said, and dim the lights in order to reduce stimulation. Give them space. Have the parent bring or give any PRN medication for agitation as needed, either before or during the visit. And if they're agitated, delay vital signs for later. So a good rule of thumb is that you're trying not to admit the patient unless it's a truly dangerous situation. In many cases, extra supports can be provided to keep the patient in the setting that they're in, and treatment can proceed that way. There are a few specialty autism and developmental disability inpatient units, however, that may be available in your area. So history of the presenting illness. So now we're proceeding to the actual visit and the interview. So this is very similar to what you do in your regular clinic with typically developing people. The most urgent problems that require help. So the first question is going to be, what can I help you with that's most urgent today? It might be hyperactivity, impulsive behaviors, elopement, explosive outbursts, affect dysregulation, which, remember, is a common symptom of ADHD, aggression or self-injury. And you're going to ask for the details and examples of when such problems arise. What are the precursors that set this off, or also known as triggers? Maybe they're environmental or medical. Are there any contributing factors? What strategies actually help in these problem situations? How is the person's mood, appetite? Are they picky eaters? Do they sleep well? What is their energy level? Is there a change in level of functioning from baseline? This helps you select the category of diagnosis that you're going to be working on. Are there dangerous behaviors? And then also question about your symptom clusters based on DSM-5 and DMID-2 for comorbid diagnoses. And also remember that abuse is not uncommon. It's really important to question and be vigilant about the possibility of abuse. It doesn't have to be asked in a blaming way. So one way to ask it is, do things ever get out of control? Do you ever find yourself losing control as the parent? And what happens next? So they might be quite happy to describe that they do start losing control and start being physically or otherwise abusive with the patient. Next, we go on to current medications and interventions, the same as in any intake evaluation. What are the psychotropic medications the person's on? What are the non-psychotropic medications? Are there allergy medications, laxatives, other medications? It's important to document all of them. If necessary, you can call the pharmacy to find these out and they'll read it to you. What anti-seizure medications is a patient taking? Are they on any dietary interventions, gluten-free, casein-free, or other diets? Are they taking supplements and vitamins? And are they having applied behavior analysis intervention or speech therapy, OT and PT? Is there parent management training? Other interventions might also be included, for example, social skills groups, CBT, individual or group therapy, Therapeutic horseback riding is quite common in this population, and massage. So we document all of these things that are currently happening. Now we're going to talk briefly about anti-seizure medications, since these can worsen behavior, especially the barbiturate-containing drugs, and others, including phenytoin, phenobarbital, ethosuximide, topiramate, carbamazepine, oxcarbazepine, and levetiracetam, amongst others. So it's important, if you get a history that the patient's behavior has deteriorated since one of these medications was started or was increased, it's important to get in touch with the neurologist or the prescribing physician and work with them to select a better anti-seizure medication. Okay, proceeding with our intake interview. The past psychiatric history, which is very similar to what you do with typically developing individuals. In addition, however, you will ask, at what age was a developmental disorder diagnosed? And were there any comorbidity details available? What about ADHD? That's often misdiagnosed as bipolar disorder. Ask for a history of hyperactivity as a child and prior medication treatments. So often the parent can tell you that really they were tried on methylphenidate at the age of 5 already. And so that confirms to you that somebody else was thinking of ADHD as a diagnosis in this patient, if that's what you might consider. Then, in addition, we ask the usual questions about previous hospitalizations, residential placements, reasons and outcomes, previous suicide and homicide attempts, police or legal involvement, and any abuse history, be it physical, emotional, sexual, or bullying. So we also want to get a list of the previous medications, as we mentioned. And these days we can use a cell phone, contact a parent or relative, and get more information. Dial *67 before you call that parent's number so that it will be unidentified on their phone. And then find out what were their best responses, what were the side effects, and what were the reasons that the medication was discontinued. Next, we're going to go on to family psychiatric history, really the same as in your general practice, but with a caveat, you're going to ask about other relatives with developmental disabilities, congenital syndromes, or other metabolic abnormalities. And we ask about immediate family, distant relatives, history of suicides, and substance abuse. So on the medical and surgical history, also very similar to in the general population, such as we start with drug and other allergies and reactions, previous genetic testing and results. So this is a difference for people with developmental disabilities, is that many of them may already have had the genetic testing, but the results may not be available. Known congenital syndromes is another difference, and we will be focusing more on seizures, head injuries, concussions. What about previous surgeries? In the case of individuals with autism spectrum disorders, approximately 2/3 of them have serious gut inflammation and gastrointestinal symptoms. So this is important to ask about in terms of food allergy symptoms, dietary history, possible celiac disease, constipation, diarrhea, nausea, a nervous stomach, which is pain in the stomach when the person is under stress. Okay, then we go on to the developmental history. In many cases, substance or medication exposure may have occurred in utero. So, for example, it's also important to ask about alcohol, whether the mother actually drank alcohol during pregnancy. Find out all the usual pregnancy details, the birth weight, problems, APGARs, Was there regression, which often occurs in these individuals around age 2.5 years? And was there early intervention, and get the details on that. So milestones are the age and the age at which problems were first suspected is important to know. Did the individual speak words by 1 year? 1.5 years did they walk? And by 2 years could they say phrases? Did they have sentences by 3 years? Next we'll ask about the educational history. Many will have had early childhood interventions, special education, using an IEP, have had OT, PT, and speech therapy. School suspensions may be on the list of their past problems. Homeschooling may be due to bullying or disruptive behavior in the classroom. Work study occurs in high school in many high schools around the country, in which a high schooler is gradually phased into a job in the community for several hours in a week, if possible, to prepare them for their transition after high school. The age of graduation can be 22 years old, since these individuals can remain in school until the year that they turn 22. Next, we go on to social history, family, work, relationships, and attachments, enrollment in state developmental disabilities systems, and a services coordinator. So the services coordinator is the person who helps the family obtain funding for many of the extramural activities, day programs, and other things that the person may need. What extracurricular activities do they do? Are they part of Special Olympics? Do they have respite workers that come into the home and relieve the parents? So these and other adjunctive things are obtained by the services coordinator at the Regional Center for Developmental Disabilities. They have to make the funding applications. So do they go to support groups and conferences? Many times there are, for example, according to different congenital syndromes, there are national support groups for that. For example, the Fragile Eggs Foundation or other foundations. What about the local autism society? Are the parents or caregivers in contact with that? So now we're going to talk briefly about the mental status examination, which we will perform first on an agitated patient in order to let them go much more quickly than before we take the entire HPR. So the rest of the HPR will then be obtained from another informant or from a parent, either in person or on a cell phone, once the patient has left. So we may also observe in the home or a residential setting for a more accurate observation of behavior. We can also have parents bring in any videotapes. Remember that group homes are not allowed to videotape these individuals. So reasons to perform the mental status exam first include what we've said, that the patient may need to leave shortly after they arrive if they're agitated. Also, it's more respectful to address the patient first. The largest part of the history and behavioral information is going to come from other informants. Self-report is often inaccurate in this population. So first we're going to put the patient at ease. If feasible, we're going to lead in with simple tasks that don't require expressive speech. Just give the person a paper and a pencil or pen and ask them if they can draw a circle, make it into a face, write their name, and write their age. And that way we can engage them in interacting with us before we ask a few simple questions. Depending on the level of functioning of the individual, obviously. But the simple questions would be, what did you eat and drink for breakfast or lunch, whichever meal was most recent? They can often remember that and tell you. Did you sleep okay last night? Are you happy or sad today? What's your biggest worry? You would be surprised how many young children of 5 years old or so can actually talk about their biggest worry. And what are you looking forward to? And I also take the trouble to record these things so that we can use it at the next visit so that they feel like you're interested in them and you know what they're involved with. So next we're going to record the mental status examination just as we do with a typically developing individual. So what's their appearance? What's their eye contact like? What are their gestures? What's their speech like? So they may be minimally verbal, perseverative, echoing questions, have pronoun reversal, and phonological or articulation disorder. They may have increased motor activity, for example, stereotypies like hand flapping or rocking. They may have rituals, touching things. They may be hyperactive, restless, fidgety, and out of their seat every 2 minutes or out of the room as well. They may have tics, TD movements, grabbing, pulling hair, and self-injury. And they may have inability to wait, which is often an ADHD symptom. So more mental status. What is the mood like? Just as in our regular practice, happy, sad, labile, irritable. What is their affect like? Are they congruent or flat in their affect? Do they have suicidal or homicidal ideation? What about psychosis, hallucinations, and the description of the hallucinations and delusions? So at this point, it's really important not to be asking leading questions. Right, next we're going to test orientation to person, time, and place. Judgment and insight, is it intact or impaired? If we are unable to record these, for example, if we have a minimally verbal individual, we can ask the person with them about their mood. Do they look happy or sad? How's their mood been today? And do you suspect that they want to kill themselves or anybody else? Or do you suspect that they might be hearing things or seeing things? And take those details from the caregiver rather than from themselves. So if we're unable to record orientation, judgment and insight, and memory testing, we simply put that into our notes. And the reason might be that they are minimally verbal. So cognitive questioning for a new patient is also not possible in someone who's minimally verbal. However, we do adapt the cognitive questioning to the person's ability level. So what is their fund of knowledge? I ask them simple questions such as what are the local sports teams? Who are the past few presidents? And then I use simple abstraction questions. For example, an apple and orange are both what? And maybe a car and an airplane are forms of what? And then I do more simple arithmetic rather than 100 minus 7 serially. So I might ask some simple addition and then proceed to 20 minus 2 serially. And then I also ask 3 wishes. So, for instance, that way a person can record what the person is thinking about, what they enjoy, and what they would like to do. So here are some important tips that we should not confuse psychosis with autism features of self-talk, rehearsal of past conversations, soliloquy, fantasy, or flashbacks as in PTSD. So self-talk in autism and rehearsal is a common feature that's not necessarily psychosis. It's especially important not to ask the patient leading questions and obtain collateral information to establish the validity. We perform physical and neurological examinations looking for dysmorphic features, metabolic syndrome, as in our regular patients, neuromotor side effects of antipsychotics, including tardive dyskinesia, and look for any signs of abuse. So for example, strap marks, cigarette burns, and frozen watchfulness in the patient. So prior to case formulation, we review every medication for benefits, side effects, including behavioral side effects, drug interactions. Review environmental contributors for any obvious suggestions regarding precursors and reinforcers. Review supports for the patient and family, and ask about possible ongoing abuse, as I said, in a non-blaming way. So we come to the diagnostic formulation. Just as you do in the regular clinic with typically developing folks, establish your working diagnosis: psychiatric, intellectual disability and personality problems, medical and neurological problems. We want to obtain past records and obtain consent to talk with other providers. Set up some basic data collection if it's not already in place. So some examples of rating scales that can be used. At the bottom of the slide, the Clinical Global Impression Scale is a useful scale to perform actually at every clinic visit so that you can get an idea for yourself if the patient is getting better or worse. Other examples of rating scales are the Aberrant Behavior Checklist, which is specifically for individuals with intellectual and developmental disabilities, and then the Achenbach Child Behavior Checklist, and various ADHD rating scales, including the SNAP, the CARS, the Vanderbilt, although the latter are not actually validated for individuals with autism. However, they can be useful guides for treatment. So treatment recommendations. How am I going to treat this person that I had to let go because they're so aggressive? Unless the patient is dangerous, try not to change the medication while you get to know the patient. As a first strategy, however, you could try to taper a medication that may be worsening behavior by a small amount. So for example, benzodiazepines, which can cause disinhibition, or antidepressants that can initially seem to help, but later cause activation. Encourage other interventions if these are not already in place. For any new medication, start low and go slow. So it's important to know that there are similarities to what you're going to be doing for people with autism spectrum disorders, but using medications in the way that you do as treatment as usual can actually make them very sick. So also, on the other hand, go up before you give up for low-dose medications that may not have helped enough but are still tolerated. Pharmacotherapy versus other interventions. So why would I prescribe medication rather than other interventions when I meet the patient? Firstly, if they're dangerous to self or others, in danger of losing placement due to behavior problems, or all other feasible interventions have been tried and proved unhelpful or only partially helpful. For example, applied behavior analysis, environmental changes, and individual therapy. What other interventions should be accompanying psychotropic medications? And this applies really to all of our patients that we treat. Arrange a person to take the patient out to do activities. So for example, the parent will pay them like a babysitter, have them take them out once a week to do activities, and they have something to look forward to, and they learn social skills at the same time. Try not to change medications over the phone unless there's clear information. It's best to examine the person yourself, whether the problem being reported even relates to the medication, so that you don't go through multiple medication trials over the phone without even seeing the patient. If necessary, see them as a fit-in if not doing well or worse. Then you're going to review or order lab and other tests. routinely review these at each visit and between visits if necessary. So genetic testing is indicated for each patient with a developmental disability. It's worth reviewing whether they've had it and whether it's up to date. But first work out the costs and the payment before you actually order it. So a caveat is that the person, in order to get lab tests done or an EKG done, may need some sedation. And in my experience, a low dose of risperidone, for example, 1 milligram, together with 1 milligram of alprazolam an hour before the visit to get the lab drawn, and repeated at the time of the lab draw, in most cases allows them to get this procedure done. Now I'm going to tell you a brief case example just to illustrate in the difficult situation how we manage an agitated patient. So this was a 7-year-old male seen in outpatient as a new evaluation, accompanied by his mother, and fortunately he was booked for the first appointment of the day. He was unable to wait. He tore up the paper on the examination couch and started throwing objects. His main complaint was hyperactivity, irritability, aggression, and self-hitting. This had only partially been responsive to medications, and sedation and weight gain were side effects. So the psychiatrist performed a mental status exam first and allowed them to leave, and later completed the H&P by phone with the mother, having established that he was still safe to transport home. So part 2, record the mental status exam. He was reasonably kempt and clean, obese, looking sedated. He had bruises and scrape marks on his limbs, but I did pull up his shirt and pull down his pants to make sure he didn't have abuse markings on his body. He made eye contact. He appeared to understand what was being said, and he escalated when any mention was made of aggression or behavior problems. He is unable to answer questions. He was minimally verbal, apart from saying no and some echoed words. He had no dysmorphic features or overt congenital syndrome. He was hyperactive and had dangerous climbing on the furniture. So his mood was irritable and his affect was congruent. There was no suspicion of suicidal, homicidal ideation, hallucinations, or delusions, according to his mother. I was unable to test his orientation, judgment, or insight. His mother reported that his memory appeared grossly intact. So I was able to record all of these things as part of the mental status exam. So next, a little later, when mother arrived home, I was able to contact her by phone, and she said he had a history of hyperactivity, impulsive aggression, and self-injury from about age 2 years. He would eat too much and his sleep was variable. They were living in a trailer home with his mother and older sister. He was unable to play outside due to a trailer park rule of no fencing being allowed, as well as his dangerous running off. So he had multiple out-of-school suspensions due to behavior problems. So his mother was unable to work. So she herself was a single mother with depression. She refused medication due to associated weight gain with trials of antidepressants in the past. And this child had had multiple previous medication trials described as of minimal help. His behavior plans had not been of any help so far. He had no respite help, and his current medications were high doses for his age and weight of chlorpromazine, risperidone, guanfacine, and clonazepam. So I came to a working diagnosis on him of ADHD combined, autism spectrum disorder, and self-injury, unspecified intellectual disability, and obesity. His predisposing and perpetuating factors included the lack of appropriate school supports for a child with autism in someone who is minimally verbal, communication limitations, minimally verbal. He may have been using some of his aggression and agitation to communicate that he didn't want to be in the visit room. Maternal depression, poverty, and lack of respite were other important issues. He was a child at risk for abuse, injuries, and elopement. So medication changes. First, I ordered a slight taper of clonazepam by 10% to avoid withdrawal. Remember that clonazepam should not be tapered more rapidly than 10% per week. And he was continued on a gradual taper of it until he was off it. This was because of the disinhibition side effects. Then we tried adding a low dose of stimulant, notably in this case was dextroamphetamine, immediate release, 1 in the morning, lunch, and a half dose at 4 p.m. And this was some improvement. The dose was deliberately instituted as fairly low in order to not worsen his self-injurious behavior. So this did improve his focus and reduce some of his impulsivity. More medication changes. I later reduced risperidone by the tiny dose of 0.25 milligrams per month in order to avoid behavioral rebound until he was no longer sedated. And the goal was to aim for approximately 0.5 milligrams 4 times a day. I tried adding low-dose atomoxetine, first at night and then twice a day, targeting also his focus and impulsive aggression. So then he was on 2 ADHD medications, and I gradually tapered him off the guanfacine due to his irritability, sedation, weight gain, side effects. And he later tolerated a very gradual taper off the chlorpromazine. So his initial outcome was that he was less hyperactive and destructive, less sedated, and his appetite decreased somewhat. So these are gradual improvements over time, despite some setbacks at times. So in many cases with a severe case like this, somebody who's severely impaired and challenging behaviors are very common and frequent. What we're looking for is a trend towards improvement. So we have to reassure the parent that if things are starting to get better, we are hoping to continue that trend. So he was able to stay in visits later. He could draw a circle and write a K for the first letter of his name. He preferred to sit on the carpet, which wasn't really a problem. He was able to say what he ate and drank, and if he was happy or sad, and he would point to the toys he wanted or pictures. So other interventions that helped alongside with the medications were that his services coordinator obtained funding for a school specializing in developmental disabilities and for transportation to and from the school. So the services coordinator does those funding and school applications to help the parent. The patient was successful in that school. He had no further school suspensions, and he was able to cooperate with speech, OT, and PT. Not to say he didn't have some days with problems, but what you're looking at is the big picture. So his mother raised money for fencing around the trailer home. She used a lawyer specializing in developmental disabilities rights who wrote a pro bono letter to the landlord saying that due to his special needs, they should be allowed to build a high fence, which they were then successful with. He was then able to play outside under supervision, and he was less frustrated when he had to come inside again. So his overall outcome, his clinical global impression scale, severity remained moderate. It had really been severe in severity. It improved to moderate simply because he still needed supervision and supports. His clinical global impression improvement subscale was rated as much improved. He did require ongoing monitoring, and I must say that I had to talk to the mother fairly frequently on the phone, but that it was not a problem. His medication monitoring would happen at visits every 2 months approximately. We would monitor his CBC and DIF, CMP, fasting lipids every 6 months, using the risperidone and alprazolam an hour before he had to have this done. He had an ongoing trial of medication taper at that time, and I wanted to continue that in the future as tolerated. Diet and exercise recommendations were reviewed at each visit. So ongoing monitoring, a genetics consultation, now that he was more cooperative, was more feasible. His mother was still refusing to seek antidepressant treatment, and so she was referred for therapy. Continue close communication with the services coordinator, who was very supportive. So in conclusion, we can serve individuals even with severe agitation as long as we are proactive about getting our preparation strategies in place before the patient comes. New patients require at least 90 minutes and follow-ups of at least 30 to 60 minutes if possible. Be flexible about interviewing the patient and measuring their vital signs. So it's really like the doctor is dancing with the patient and just seeing what they can tolerate, what is going to upset them, and letting them go if necessary. And we can record the mental status exam even for minimally verbal individuals and tailor the treatment selection to a diagnosis as well as to the individual patients. Perform a detailed review of each medication at every visit. So I want to thank you for coming to this lecture, and I wish you luck in the very gratifying experience of treating folks with autism spectrum disorders.
Dr. Hellings, thank you so much for your lecture. I really like how you provided us with a systematic approach, a step-by-step process about how to evaluate a child with a developmental disability when they come to your office for an outpatient appointment.
That's great. It was a pleasure. Thank you.
Would you mind if I asked you some questions?
Not at all.
Okay. So my first question is, why do clinicians use their own observations and collateral information from caregivers for the mental status examination, including in patients who are minimally verbal?
Well, the mental status examination, obviously in patients who are minimally verbal, is going to be difficult since they cannot answer questions. However, the caregiver can answer those questions for them to a certain extent, but it's also important for the clinician to use their own observations and judgment when they know the patient and they can see for themselves whether there's actually been an improvement. That's observable. Secondly, even high-functioning individuals with developmental disabilities may not have accurate self-report skills. They are also more prone to answer yes to leading questions because they have learned that answering yes is more pleasing to people than answering no. So we run that risk of misdiagnosing them if we ask leading questions and don't obtain collateral information. In addition, to help us, we can set up some basic data collection so that we can see on a piece of paper whether things are getting better or not.
Those are really helpful tips. Thank you.
Great.
Another question for you. While aggression, self-injury, and property destruction are common presenting symptoms, how does clarification of co-occurring diagnoses using working DSM-5 and DM-IDD-2 criteria help clinicians in selection of medication trials?
Well, it can be very confusing for a psychiatrist starting to serve this population to work out how to select medication, for example, simply for aggression. But it's vital for them to work out if the aggression is impulsive. For example, could this relate to ADHD as a diagnosis, to find out early history of hyperactivity, impulsivity, and previous trials of ADHD medications, which they can do from a parent or sibling, either in person or on the phone. And remember that bipolar disorder is often misdiagnosed when really the person has ADHD. In addition, for example, if you have somebody with really severe OCD, it's important to first establish that they are not manic if you are considering giving them an antidepressant for the OCD, since that will make mania worse. So the advantage is that even general psychiatrists are used to using DSM diagnoses to guide them in medication selection. And so in serving individuals with developmental disabilities, they use the same principles and have to be a little more careful in teasing out the details of why they are making certain diagnoses.
It really is important to take the time to understand the multiple sources that could be contributing to a symptom, you know, multiple factors.
The
right?
devil is in the details.
Yeah.
Yeah.
All right, last question for you, Dr. Hellings. Why is it important to carefully review all medications the patient is taking, including non-psychiatric medications, for indications, benefits, and side effects?
Well, for example, as I mentioned, medications can make these people very sick. They can have side effects that are more pronounced than people in the regular population, and they are at the same time unable to voice the side effects or refuse to take the medications. So it's up to us really to look at all the details of whether the behavioral worsening occurred at the time that a certain medication was started, and it's also important to look at non-psychiatric medications, including, for example, laxatives and allergy medications. Many times these individuals pick up several of these different allergy medications, which can contribute to insomnia, which can contribute to behavioral problems. And laxative overuse, where the person is having frequent diarrhea, can contribute to their not absorbing essential macro and micronutrients that are essential for neurotransmitter synthesis, as well as just generally leading to a feeling of being unwell, which can impact behavior.
Absolutely. Thank you so much, Dr. Hellings. I'm going to remember so many of these points that you made today when I am in clinic on Monday.
Thank you
really
very
appreciate
much.
it.
Thank you. It's a pleasure.
And thank you all for joining us today.
Thank you, everybody.